We'll move on to the next talk from one of my mentors, Dr. Satyan sir. I met Satyan sir long time ago when he was attached to Arvind Coimbatore. He's gradually moved on and he has his own setup. And sir has very unique takes on various things, be it gonioscopy, be it NCT, be it SLT. So I would just like to know sir's take on SLT in today's practice. It's a very controversial topic. Some say it's extremely good, some say it's not good at all. So I just would like to know what is the role of SLT today in the Indian scenario.
Okay, fine. Thanks, Ajit. I have no connections with any of the industries, the company, whichever I'm talking about. Of course, we all know that as we are having only a glaucoma people here, I'm not going to, dwell with too much of this, but I'll just give you the brief of it. Again, for me, we are all kind of, I would rather use this word itself. We are adamant in not accepting few, truths. The patient adherence and persistence, we all know that it is quite poor in glaucoma. Like 90% of them are not adherent to their medications, and of course, the persistent is going to be another question. When we did the study on the follow-up, these are all the problems that they have. Lack of knowledge seems to be a big thing. That is, when I was at Arvind, we did the study, and so there are a lot of issues the patient has in following up the either follow-up or for the medication usage. Everything there's a very common thing which we really look at is that most of the patients miss some drops, some miss most drops, and few miss all drops. That is in US context, but there is a reversal in our own context. See, after the second bottle or the third bottle, the purchase of medications, we think they are buying. It is not the truth. So there are many reasons. We don't want to go into that all those things now. There's a mechanism of SLT. This is one of the most commonly used slide ever you can see. The SLT uses the Q switched 3 nanosecond pulse frequency double ND-AUG 532 wavelength green laser. And earlier when we started the SLT, the beam size used to be a little smaller, thinking that we have to really focus on only a small area. But then over a period of time, the companies evolved with a larger size so that we can easily shoot the trabecular meshwork comfortably. And mechanism of action is the laser energy selectively targets the pigmented trabecular meshwork, the endothelial cells with no coagulative damage. I don't want to again go into this all these theories. So how does it really work as a primary therapy? So we say it is as efficacious as the PGA. We are not looking at the other PGA. The comparison is only on the lateral prost. So it really compares with the lateral prost. Whatever I'm talking about is these are all virgin eyes. It's all not been treated earlier. So the virgin eyes, the SLT works perfectly all right. Is the luminous works, is the LX works, or other machines works? For me, I've used all that machines. For me, the Apasami works much better. I really don't know the reason, but the reason when I went back and assessed, the only reason I could say is this could possibly because of the super Gaussian curve. They use it in their machines in the lasers. All the machines they use the super Gaussian mode in their laser machine. So that could possibly be the cause. I don't know why the Apasami machine should work much better than the other machine. I could only theoretically I could see only this possibility. So this one thing, as the primary therapy, we know that definitely it is either equivalent or probably a little lesser over a period of time. It may work. So this is the long term, like 5 years. People keep saying that is it for an year, like we talk about the mix for an year or two. But now we have the 5 years data is definitely it works for 5 years. Many of them, provided there's a controversy, as you are mentioning about the controversy. Controversy is if you think the Swalby's line as a pigmented trabecular meshwork, and then you try to do the SLT, you don't get any result. Doing a proper gonioscopy, understanding about the gonial lens and doing the proper gonioscopy makes all the difference. So people should do a proper gonioscopy, do it properly, then you definitely will have a good result. So one of the doctors who was really saying the controversial things about the SLT, I had just went and asked him how many lasers you have done. He said, "No, Satyan, I haven't done anything. People are saying that they didn't get the good results." And I asked who are all the persons. Then there's a few more doctors. Then I asked them also. They also said, "No, no, we have just studied somewhere." So that is how the things are. We have to be a little cautious about how things are done. So 93% of the success rate in, if you take the medication, for example, timolol, probably it works for only about 70 to 75% of the people. The remaining 25% it doesn't respond. It is not that medication works for everybody. Similarly, SLT may not work for everybody. As an adjunctive therapy, patients are on medication. You got to stop the medication before you do the SLT. There's always a feel factor that once I stop, what happens in the next couple of weeks? Nothing happens. Even if it goes to 30, nothing happens because the patient was not using medication for many days, many years. So 2 weeks or 3 weeks of not using the medication, it may be having some effect, but it is not going to blind the patient overnight. So definitely it has an effect of around 3 to 4 millimeter of IOP drop. And we all know that the fluctuations are one of the main reasons for the progression of the disease. But then when you do the surgery and SLT seem to have a flattening effect on the IOP fluctuations, that is where it really helps to an extent. And as a replacement therapy, this is how it works. Like if the patient is on one medication, you can probably take off the completely about an 86%, and then you can see if the patient is on 4 medications, 32% of them can be reduced with 1 or 2 more medications. So let me just show you the Indian context. I'll just okay. So what are the main side effects that we have faced is never do SLT below 50 years. If you are going to do that, you are going to burn your fingers. Which patient, I don't know. We are going to burn our fingers. But below 50 years, somehow they all have a high IOP spikes. It's better not to do. They'll have a blurred vision, but most of them will be okay. But applying the steroids immediately after the SLT is the one thing which you should not be doing it. Once you do that, then it will not work well. Main indication is, of course, the primary open angle glaucoma is the best to have with the nice wide open angles. All primary open angle glaucomas, we have to compulsorily avoid in uveitic, aphakic, NVG. All these patients you will have to avoid because it will never work. Probably it is going to be more harmful. Pseudophakic glaucoma in aphakias, young ones, pigmented glaucomas, again it is, at least in my hands, it is doesn't work as good as in other primary open angle glaucomas. So we will just, this is a major clinical, I'll just go through this study. So there were 600 patients were included in our trial. That is one of the major trials when the Luminous was launched. At 4 centers we did the trial. So it is 150 patients per center. And unfortunately, I came out after a few days of the trial was started. I think George has published the article after some time. So when I just was there, it was 48 patients who were completed on the study. And these are the results. About 23% of them had IOP drop. Had the first day and then 3 months post laser. This is how the IOP reductions were. But then over a period of time, again, we saw that the IOP drop was more sustainable. The problem again with the machine is the Luminous machine I'm talking about. It is very difficult to do because the head is very complicated head. Upper machine is as easy as how you do with your YAG laser, YAG capsulotomy or PI. So whatever the lessons I learned is, don't overdo things. Don't tell the patient that you're going to really completely treat his glaucoma. They have to come back for a follow-up, good counseling. And there are non-responders. You may think you just do it, and then if the patient is not responding, whether you can go for laser next week, don't do that. But once they are responding, and if you feel it is not adequately controlling the intraocular pressures, you take them up after 2 months. That is the best time where you can really do the repeat lasers where they were responding to your treatment earlier. Otherwise, it is not going to work. So this is the lesson again I have learned is seen in 10% of the patients. Younger ones are the ones Many of them, including some of the doctors whom we are treating now with the trap, they don't just respond. So it is very difficult to control the intraocular pressures in those patients where they had IOP spikes, especially the young ones. So do not overpromise. Choose elderly patients. Primary treatment works best. Choose retreatments in only in responsive patients. Some of them they do have this question of either I do 180 or 360. You got to go for 360. There is no 180 in this. Thank you.
Thank you so much.
Yeah.
Thank you so much,
So I
Satyan sir.
just thought I'll give you some practical points rather than just talking some theory for you,
Yeah, yeah. And
because all of you are good in theory here.
yeah, yeah.
I'm not against luminous. If you
No,
want
sir.
one, I'll give you that
I'm
my
just
machine also.
saying that, sir, in our scenario, we have done around 10 cases. Out of them, 6 responded. So it's not that it doesn't work. Sometimes it works, and as you said very clearly, sir, we do not have to overpromise that this is something which would
Yes.
basically take care of everything. So you have to be very and sir, in few of my patients, I am doing a follow for last 4 years, and their pressures are not going above 12 millimeter of mercury. So it sometimes works very well. In
The other
few years.
trick I can give you is don't do those who are having less than 22.
Okay, sir.
Okay, NTGs and all will never work. The ideal is higher the IOP, better the results. 25, 27, 30, 35, they will all respond beautifully.
Sir, in many of my patients, as you have said that it should not be done or avoid doing it in more than 50 years. Many of the patients who are
Not more
trauma.
than 50,
Less
less
than
than
50.
50 years.
Okay,
Less than 50.
Okay, sorry,
More
sorry.
than 50 years, of course, obviously you will have to. Yes,
Sir,
madam.
No, sir, in the young patients also it was working in trauma and treatment
It works. It is all anecdotes that we are talking about. When you do a little larger volume, and then you will start understanding whether it really works. Some patients, if it works, it works. I'm not denying that fact.
no harm, sir. At least we can give it time.
For me, I will not touch because I've burnt my hands. So I will not touch in those with the traumatic eyes, younger ones, because we are going through even after 15 years. I'm going through that phase of unable to manage them. We have done a trap, we have done a repeat trap, we have done everything possible, tubes, psychology, CPC. I mean, one patient I put uh, two tubes are there. So once they are having a high IOP, it is extremely difficult to manage that.
yes, sir, I had some experience of doing about 38 patients whom we followed up for 2 years, which were post PKP with adequate visualization. But as you were saying, around 6 of them for 1.5 years or almost 2 years till we studied. The significance was this, that we could put them off instead of 3 glaucoma drops, we could come back to 1 glaucoma drop. So even if it is percentage wise less, sir, but it makes a lot of
Alakesh,
difference.
nothing is wrong. As long as it works, it's fine. But whatever we are talking here is what is the real good indications where you can expect a good reasonable amount of results. These out of the box patients, yes. If you feel it is working, it is working. I'm not denying that fact. But can we just openly say at the podium you do in every patient and you have a result? That's what the concern for me. I can't openly say that you do in every given patient.
Absolute contraindication is only when you have done a 360-degree gag. Otherwise, you can do anywhere. What sir is saying are properly established recommendations for best case scenarios.
So when you are staging in the AOS podium and then saying that you do in every case and then you'll get a result is not the ideal way to do things.
Sir, considering open angles now with micropulse laser also being available, which patient would you choose for what? Now the options are so much more. With,
Micropulse is completely different, doctor.
yes, open
Micropulse we are
angles.
not looking at for either open angle or angle closure,
Yes, sir.
nothing.
So open angle glaucoma
You are
on 2
talking
or
about the
3
MP3. You are
medications.
talking about the MP3, right?
Yes.
Okay.
Would you choose
MP3,
micropulse or SLT?
I think both are completely two different things, which we are not even comparing.
No, sir. What would you offer the patient if you had both the options?
No, that's what I'm saying.
Yes.
The indications for micropulse is different as a primary therapy, and for the SLT is completely different. We are not going to do in those eyes where 35, 40 or 45, we are not going to do SLT. Those patients I will definitely go for a micropulse, because micropulse is one thing where you must understand we can reduce the intraocular pressure, but it is not sustainable. You will have to go for either a repeat procedure, either one time or two times. Then it works. The second probe, the type 2 probe will not work in any patient. So we had a discussion that they have to change the probe. They are willing to change it. They're willing to give it for the trial for probably next month we'll start it. But the second probe is completely not working.
Yes, sir. Yeah.
The first probe is working, but for economical reasons, for Indian context, they are not willing to give it to us. But then second probe, 0 results in all the centers. All the centers. So I just told them very point blank, you have cheated us. You make sure that either we take you to the court, and when you are saying something, some settings, and if it is not working, that is your mistake. So you got to replace the probes, or you do the first trial and then come out with some settings, parameters, which one works. If it doesn't work, you change the probe, that's it. So it is very harsh talk. Yesterday we had the company. So they are also willing to accept. Initially they said, no, in US it is working. Don't lie. Let me talk to the people in US. But then they said, no. They are also having difficulties. But you know how they speak. But we don't have to really completely take away. But SLT is one thing, doctor. Up to 35, definitely you can look at doing the SLT. As I told you, is it the super Gaussian mode in the upper semi machine is working much better? I really don't know, which I'll need to kind of go through it and see.
Another thing I wanted to ask you, post SLT, what is your normal
No medicine. Unless the patient says that I'm not comfortable. But if you give the anti-inflammatory or steroids, then the response is, you need to allow that to have at least minimal inflammatory response is really required. Too higher an IOP, of course, you can give a Diamox, don't put them on topicals. Yeah.
Thank you so
Thank
much,
you, Ajit.
Satyan. I just wish there were more people in the hall because they would have benefited from this particular discussion. We would have. Thank you so much.
Thank